My name is Catherine, and I'm a registered nurse and hold a professional education portfolio for a large nursing organisation. I was born and raised in the lands of the Awabakal people in New South Wales. My father wasn't well during my childhood, which meant I spent a lot of time in hospitals. While my father was at home, my mother and I would care for him. From a young age, I learnt his medication routine, how to help him with his oxygen, and generally care for him. When my father passed away, my mother completed her certificate as a nursing assistant. The care my mother provided to my father and a passion for her job is what drove me into nursing. I completed my Bachelor of Nursing at the University of Newcastle and started working at a small hospital. While I was working at this hospital, I was fortunate to have a nurse educator that was motivating, engaging, collaborative, and had clear expectations of the nursing role. It was this educator that explored moral purpose, not just as an individual, but as a unified team to make a positive impact on the world. This nurse educator had a significant effect on how I perceived my nursing footprint, the consequences of my actions, and how I worked as part of a team. I was immersed in a workplace that fostered a positive culture, a supportive environment, and that collaborated with learners. It shaped my expectation of how nursing educational leaders should behave. As I progressed through my nursing career, I knew I wanted to be an educator. This stemmed from my experience teaching and mentoring nursing students and novice nurses. I've worked now in nursing education for several years through a range of different roles and educational settings. Educational leadership isn't always visible. However, it can be seen throughout nursing practice. By examining leaders, it reveals how they use power, influence, and educational theory to impact changes within the working environment. During my nursing career, I witnessed the practice of many nursing leaders and have seen the utilisation of power and influence in a range of ways to affect actions within the workplace. Nursing leaders can employ tactics to affect the mood, feelings, and emotions of individuals to achieve an aim. The use of coercive power is used within the healthcare environment, and I have seen how leaders use tactics such as force and a fear of punishing undesirable outcomes. Within nursing leadership, the implementation can be seen through rostering practices, patient allocation, and restrictions on educational opportunities, leading to feelings of disempowerment, which contributes to poor workplace retention and a negative workplace culture. Through reflection, I found that this type of leadership practice is not how I wanted to lead, and that it would go against my core values and beliefs. Whilst engaging in reflection, leaders can be self-aware of how they are influencing emotions and team psychology within the workplace. Whilst working in clinical roles, I have developed my skills to create a large knowledge base to draw upon through clinical teaching. In having a strong clinical base, I was able to develop referent power, with trust being the foundation of how I influence change within the workplace. This source of power takes time to establish. Within the nursing profession, leaders who utilise referent power must be able to walk the walk through moments of heightened stress to form credibility with others. However, challenges that I have faced with this power is that it's not transferable, leading to increased responsibility on myself to keep members of the team engaged and goal-orientated. By building relationships, empowering, and collaborating with those around, a person demonstrates they have skills to lead. They can improve the team dynamics and inspire people to achieve a shared goal. I recently sent the power quiz to my first nurse educator. The outcome was that she was referent in power. This cementing that I'm on the right track with how my leadership skills are developing. In building on my ability to establish referent power and understanding limitations, I was able to employ adaptive and distributive leadership when faced with a global pandemic. As the healthcare system shouldered the burden of the COVID-19 pandemic, I was tasked with providing education and support for nurses to look after patients who were infected. Adaptive leaders engage with complex problems, adapt to meet the challenge, and thrive from the experience. By utilising the balcony metaphor that's discussed by Heifetz, leaders can gain a better overall perspective of the organisational requirements by taking a step back and observing. Within nursing practice, this has relevance when leading in a medical emergency. Nursing leaders can scan the situation and understand what is next required to perform advanced resuscitation. The strain that the COVID-19 pandemic has caused on staffing and resourcing has been significant. Without utilising distributed leadership, the healthcare system would not be able to manage. I hold strong values of collaboration and inclusivity, this being a strength in applying distributed leadership. While the world as we knew it was plunged into uncertainty, I ensured that the workplace culture fostered engagement and encouraged staff to think of innovative ideas to improve work practices. In utilising this theory, in sharing ownership and decision-making among multiple individuals, the workload was shared, connections were made, and the nursing team were committed to safety and improving patient outcomes. During a global pandemic, distributed leadership allowed sustainable change and expanded leadership capacity. Reflecting on my career, my personal values, and the leaders that I've met along the way, I understand how this has contributed to shaping the leader I am today. My experience in drawing upon referent power has been centered around relationships of trust and my values of respecting the interests of individuals in my team. The trust that I have built create the foundations to apply adaptive and distributed leadership in times of uncertainty and heightened stress, allowing the team to grow stronger and thrive through the experience. I recognise that I still have much to learn, not only about my leadership, but about myself. The process of leadership is one that involves continual learning, embracing perspectives, and involves challenging existing assumptions to professionally improve. In utilising reflection, there are aspects of my educational journey that I could improve, such as being on the balcony more often. However, when faced with short staffing and decreased resources, one has to be on the dance floor to promote camaraderie and further cement referent power. Whilst I don't work in a clinical setting anymore, I still create a safe, collaborative, and encouraging environment for my team. In fostering decision-making and a culture of care, I have influenced a shared goal to make nursing education accessible across New South Wales. I was lucky to have my first nurse educator instill a sense of moral purpose, which has had a profound impact in shaping expectations of myself and those around me. In conclusion, my career thus far has been incredibly rewarding. It has been filled with challenges, growth, collaboration, and witnessing nurses come together to achieve great goals. I'm grateful for these transformative experiences that have taught me valuable lessons in creating a supportive environment that have shaped me into the leader I am today.